Who's first?
Hi, I'm Polly Walker from World Vision International. I'm very interested in equity. It's one of the things that I have always tried to embed in our programming. And you mentioned, Miriam, that there were 3 components of quality, so equity, effectiveness, and efficiency. Embedding equity from design. I think this is something that we just don't do very well as NGOs. We do it retrospectively and try and look at have we reached the most vulnerable. Most NGOs say that they target or reach the most vulnerable, and yet we don't do that from design. So I really want to get your thoughts from the reach out experience. How can you embed equity from design in a very simple way? Yeah.
Thank you. Yes, over here, David.
David Booth from ODI. A couple of questions about the meaning of some of these terms that are being used. Political. I mean, would you agree that that doesn't just mean sort of being smart about the politicians and their likely behaviour, but also paying due attention to, for example, the power of senior doctors, which is, I imagine, very difficult for lower level health staff to challenge, and the incentives that frontline staff face, which may encourage them, for example, to approach a particular thing as a tick box exercise rather than as something they should be actually thinking about. And then the other question is this locally led one. I mean, would you agree that we don't want to go overboard with this? I mean, there's a very important idea behind that phrase, I think, about harnessing real local effort by people who actually know what the situation is and are suffering its consequences. But would you agree that locally led in practice is at least partly about getting the right kind of facilitation, which may not be local? I mean, it may not involve a researcher, but it's the kind of sort of stimulating influence of something from the outside, which actually gets people together thinking outside of the box, and gets people of different levels of seniority actually able to speak together, because I suspect in most health systems that doesn't happen a lot. It doesn't happen naturally.
Thank you. One more question, please.
Hi, I'm Clara Saville from The Brook, which is an animal welfare organisation. I work on the animal health side. And my question relates to the last point there, that if the locally identified priority doesn't match with what your data is suggesting as the priority, which way do you go?
Great, thank you very much. So we've got questions about equity, about what does being political mean, about what does being locally led really mean, and what happens if local ideas conflict with, I suppose, quote-unquote, objective data. So let's go left to right, and also Lillian will join us on the phone also, I hope.
So Lillian after me?
Lillian after you, Olivia.
That's me first up. I don't think I'm going to try and tackle all of those because I think that won't quite work. But I'm going to start with the idea of locally led and this idea of harnessing local effort. And something that I would like to say we do a lot of when we're thinking about quality improvement initiatives is it's often a team effort and a team approach. So this idea of the right sort of facilitation, when quality improvement projects happen and they are funded from, let's say, the American government fund a lot of quality improvement, they often get quality improvement experts in to do training on how to be part of a QI team. And that will involve people of these different levels of seniority that you refer to. And so that facilitation is there. So that would be something that you would front load into a QI project. But that doesn't really help us with what happens when you try and get to that facilitation if you're trying to embed quality improvement. So a training might occur, but what will happen a year or two down the line? Do you retrain? Do you need to get external people in to facilitate that? So that is a quick response on that one from me.
Okay, thank you. Lillian, are you there?
Yes.
Do you have any responses to the questions?
Yes, I do. On the issue of, maybe let me start with the one for locally led and what it means. From our experience, and I'll match this with a question on if the locally identified priority doesn't match your data, which way do you go? Mm-hmm. That's it's very significant and very important. In many cases, we've had gaps or challenges in getting people to use data for decision making, but the process has to be slow, and you have to make sure that the data you present is useful to or for the policy priority that the local leaders have identified. And so one of the things that has worked well for us is if the local leader wants one thing or they prioritize one area, we would not write that off. We would still consider what they're doing and try and see how what we are proposing matches that. So for example, if you want to do community health worker programs, and there's a plan to implement the policy. Within that, we know the overall priority is that we need a new policy. We're kind of thinking we need a new cadre of community health workers, but we also believe that quality improvement is important within that. So what we would do is we would participate in the processes around the whole policy and support with data for whatever it is that they have prioritized, but at the same time introduce why it's important that quality improvement as an approach is significant and get it into that policy process. So we have become part of the process, but we facilitate what the local leader already has prioritized, and that usually has helped us really get in or get buy-in for what we have found from our evidence or our practice.
So it's a kind of a you scratch my back and I'll scratch yours type of process.
Yes, something like that. Not necessarily very robust, but
could you give me an example of some of the things that these local leaders want to see in the health sector?
We've seen, and one of the studies, in fact, the PhD student we're working with has been interviewing a lot of the local county leaders, and they like to see physical issues, something physical. An ambulance, a health facility has been built, and that goes with the local leaders, the political leaders, and the community. So that's what they would state. So in the process, you would say, okay, how do you now come in and start providing the evidence that as they build this, because they've already built that or they're prioritizing, how do you make sure that within the plan they would prioritize other things like community health programs, which seem to be taking a backseat sometimes in some of those counties?
That's very interesting. I'd like to open that up to the audience a little bit and ask, do other people have similar experiences that local politicians often have a preference for hardware or infrastructure rather than actual systems and quality care and such like? I can see a few nods, but nobody's actually offering a story or anecdote. Okay, well, we'll move on. Thank you very much for that, Lillian. Did you have any response? Did you have responses to any of the other questions?
The one for what political means is also an interesting perspective. I think and the power of the senior doctors, for example. As I mentioned, even before devolution, though the offices were not political in nature, the more senior doctors would be given those senior directorate positions or senior government positions, and they would determine the policy or direction. And it is true that it was difficult to cross that barrier. And what devolution has brought, in spite of all the changes, is that now we can have prioritization at a much more local level. So it's just understanding what is that power? What is the interest of this person? Is it that they are a senior surgeon who's been working for 20 years and is now in a directorate position? Or is it someone who was a public health officer and is now the Minister for Health at the county level, whom you may be able to actually speak to about a little bit easier and get them to see the priorities at that level? So it varies, and there's a wide spectrum of this political force. It's just to think at that point where you're working, at the level you're working, if you're at the dispensary, if you're at the hospital itself, who do you need to know, and whose priorities do you need to really be aware of to get your agenda?
Okay, and can I ask, how do you find out those things? How do you go about getting that information?
You just have to talk to the right people and keep your ear on the ground and participate in the relevant forums.
Okay, thank you very much. I'm going to move now to Miriam to see if she's got any replies.
I'm going to take the equity one, which is challenging one. I would say that nobody goes to work in the morning to make things more inequitable or to provide a poor quality service. It's something you do by accident. And how we define equity is an important part of that. So, for example, coverage. You could say, okay, this area is covered, catchment area of that, community health worker there. But when you follow them round, you use some spatial modelling or a mapping tool, you find out that they're visiting the houses that are closest to their house. And then maybe because most of the morning people have come to the house, they're queuing, they clear the queue, then they give a talk, and then maybe they've only got time for 1 or 2 visits. It's not that they're not working, it's just that people that live further away from their house never get seen in a 3-month cycle or annually or whatever. So if you had your indicator as coverage, here's a community health unit and there's a community health worker for that catchment population, actually the coverage is inequitable. So part of it is in how we define and how we plan. And then part of it is in the methods that we use to measure what we mean by equity and planning for that early on. Because you talked about how do you do it in the design. And I think that we need to be upfront about using methods that assess these different dimensions of equity. And some of those methods are not easy and not cheap. And there's some things you can only find out from door-to-door surveys or from spatial modelling or from a different method. So it's innovatively using methods and getting community perspectives on methods and getting community perspectives on equity as we plan. I don't have all the answers to it, but I do know it's a lot more than just saying we're going to reach vulnerable groups with our target population is this vulnerable group or that vulnerable group. It is design, planning and methods, evaluation. Nothing new in public health, is there?
Okay, Miriam, I'm going to ask you a question that's come from a member of our online audience now, because I think that's also pertinent to equity. And that is that, do you find, it's from Rogeru, who's a student at the Liverpool School of Tropical Medicine, and he or she asks, do you find that only a certain subpopulation in the community attend community dialogue days, e.g. middle-aged women, or do they adequately represent the spectrum of needs within any community?
Lillian, you might be able to add on here, but the data I've seen is that women are service users and providers, and the dialogue days are dominated by men. That's what I've seen. Lillian, do you want to add on that?
Lillian, are you there? I think the phone connection may have been... Lillian, are you there?
Yes, I'm here.
Did you hear Miriam's question?
Yes, I did. It's true that the dialogue days and a lot of the community meetings and events are dominated by men. And unless there's a deliberate effort to get women, then they don't participate. However, like the community health workers themselves tend to be more women than men, or they might start equally, but the attrition is higher among men. So when you have a meeting calling community health workers, you might find it's more women, but in the general community forums, including the process when community health workers are identified at chief meeting, are usually male dominated.
And do you have any strategies to address that, if that's a problem?
Not quite. And it's one of those things that we've just been observing and addressing in terms of thinking through equity. There are certain times when you might work with a project that is doing something, some outreach activity or the other, and is targeting and mobilizing women. And then you combine your, for example, dialogue day with such an event. Or have the dialogue day on a market day when you know maybe more women will appear, and then you mobilize them to participate in that activity. But even within that setting, you might find that the women might speak less than the men, and that will just take time, unless you draw them out with something particular.
And I presume that a knowledge of local context is important here if you are to reach those people whose voices wouldn't otherwise be heard.
Yes, it is. And it even in a country like Kenya, it varies very widely from one community to another. For example, among the Maasai, it's just the men who will speak, and the women are not allowed to speak in that forum. So if you want to hear their voice, you have to have a separate meeting for them.
Okay,
Yeah.
thank you.
I also wanted to say something about the issue of about embedding equity from the design stage. And one weakness that most projects have had, and we had this coming from the district teams themselves, is we always, as the different projects and NGOs, always pick whatever is easier or simpler. So we'll always go to the urban areas or to near the towns or the roads, and they find it very hard to make us go where the problems actually are. And that sometimes is also a problem that's coming from the funding perspective, and you don't have adequate funding, or the health burden seems to be not so clear in those remote areas, and so they're not funded. And it's something we need to think differently about.
Yeah, I think that's a very interesting point, that there may be both issues of funding and issues of motivation and incentivization vis-a-vis health staff about reaching those more marginalized groups, I suppose.
Yeah.
Okay, great. I'm going to move now to Vicky to see if she's got any responses to that initial round of questions.
I was just going to talk about locally led and politics. Just from my experience of either being involved in implementing quality improvement programs or evaluating projects, I think in terms of when we use the word talk about working politically, I think what I've really seen that is missing is people having the skills to negotiate, to influence, to network, to communicate, to advocate. Often those skills, it's kind of assumed people either naturally have them or they're going to somehow learn them, because they're often not part of professional of development when you're training as a nurse, as a health worker, as a midwife, as a doctor. Often those skills are not things which are part of professional training. And I think those are actually, when we're talking about working politically, it is about, I think as you said, David, it's about being able to question a senior doctor. And quality improvement actually can often allow, often you will see for the first time people working as multidisciplinary teams. And if you can build people's skills in influencing, negotiating, then they may then have the confidence to start challenging people at a higher level. And also, though, when things work, to be able to start advocating and communicating. But that does require building those skills, because there are real capacity gaps there. I think I've seen a lot of projects where there have been some very successful initiatives, but then whose job is it to advocate, to communicate that to others? And often people are, some of the more junior health workers and senior ones are lacking those core skills to be an effective health professional. So politics for me is about negotiating, communicating, influencing, networking. And just the other thing about locally led, I do agree. I think getting the right facilitation is really important, and that often to have something locally led, having an external facilitation can actually be very powerful. I think when I work as an international health consultant, I can often ask questions which are perhaps more difficult for someone to ask who's working and embedded within the system. And I will often say, what difficult questions do you want me to raise? So I think that external facilitation, but facilitating only and not pushing the agenda, and there can be a very fine line between that. And again, identifying quality improvement champions. So finding people locally who have really got it, who are those early adopters, and building their capacity to become those local leaders. As an external facilitator, you're often in a position to do that, to identify those people, and for them then to become those local leaders and push. Yeah.
Great. I'm going to ask another question that's come from our online audience now. This one from Sumyadeep Baumik, from the Liverpool School, who asks...
I was well done.
I was lecturing them on Monday and told them they better all join the debate.
Well, Sumyadeep asks, what does adaptive programming mean to external management/development consultants who are often expected to give concrete advice of what to do? And I think especially when task shifting in terms of universal health coverage often faces locally led resistance by, for example, doctors seeing a loss in their business, particularly where the private sector is strong, as in many low and middle income countries. Is there any evidence or experience on the political aspect of this from the panelists?
I think we've probably got some people in the audience who are quite well equipped to answer this question too. But in terms of when external consultants are expected to give concrete advice on what to do, I think this takes us right back to the early planning stages of the projects in which we work, when it's a question of, shall we say, advocating or even working politically with our donors as to not going in with, here is the solution to a problem, and saying, how about taking an approach which is adaptive? So starting from that point, rather than saying, we've got a solution, this is how to go about it. That's how I would start.
Can I ask, is there anyone in the room who has worked on a health project which is sort of self-consciously politically aware and has built in a political dimension? Yes, please.
My name's Ellie Brown, and I'm not from Liverpool. I'm from Options Consultancy, and we do a lot of programmes in quality of care and accountability, and in maternal and neonatal health. And and I think there are so many issues that you guys have raised, which I thought was really interesting and really echoes with our experience. We've got several programs which have really overtly sort of grabbed the bull by the horns and become political programs, which I think is a line that many donors and programs don't want to cross because of, I think, political legitimacy. For me, I think accountability and quality go together. And I find accountability a really, really useful concept for working with quality, because actually you want to have processes that build accountability at all levels of the health system, starting from community and starting from specific groups within the community, and then holding health service providers accountable, health service providers themselves becoming agents of change, holding district level teams accountable, and in our programs that works across those different levels of programming. I think where I differ, or where I can maybe offer insight, is that the methods that we use really have taken a decision about how quality improvement should happen. And for us, the main barrier is the manual that you held up, which is pretty representative, I think, of many quality of care standards and checklists that you'll find at national government level, which are so massive that they're absolutely unwieldy. Then you just make more problems for yourself in terms of building capacity to look at data, for your district health management teams to be able to use that data effectively. And you're back to square one effectively, because data really is the problem. It is a problem that local decision makers cannot access this data. They will often access it, and it will be 2 years in arrears by the time they get access to it. As you said, at local facility level, facility health managers often don't have access to it at all, which is a scandal in itself. And when you get down to community level, then they will have absolutely no access to the data. They won't often be aware of what they are entitled to in terms of healthcare. So it might be, for example, in Nigeria, that pregnant women are entitled to access bed nets and intermittent treatment for malaria during pregnancy, but they won't really be aware of that. So our approach is really based on scorecards, and I think this is where we find that we don't chuck out the national guidelines, but we focus on scorecards which are rapidly measurable. The methods that we use can be administered by telephone. They don't involve health facility visits. They produce very quickly data that can be used, and often that's measured every quarter. So it's as close to real-time data as we can make it, and we've done a lot of work putting it onto mobile phones as well, so that it's an app that can be accessed and crunch out data very quickly. So actually then your data capacities don't need to be that high. In
case anybody isn't familiar with the scorecards methodology, could you just say a little bit about what that is?
So they vary by different programme, but they will have key indicators. So for maternal health, it will be signal functions. So how ready is this facility to be able to conduct emergency obstetric care? How well are they? How much availability do they have of key life-saving commodities? For example, do they have health workers who are able to do a normal routine delivery at that time? Is the facility open 24 hours a day, which is really important for maternal health care? And I think then...
And who's providing the data?
The health facility managers. Okay. And so we'll work with the district level management teams or with external teams sometimes, which is not the ideal situation, to collect that data. Mm-hmm. I think what really comes out is that you can't be completely locally led, and nor would you want to be, because when you have a scorecard, you'll see that across different facilities, things do vary, and it doesn't vary because of resourcing particularly. Mm-hmm. It varies because of other aspects, which might be political will, or it might just be that you have got some very good staff who are very motivated in that facility, or it might be things like, you've got better staff accommodation in that place. There are lots of things around commodities which require a systems level approach, but you can definitely use the scorecards to put that data back into the hands of people who can then advocate for better supply chains of commodities which are life-saving. One issue that we come up with again and again is about the lack of access to oxytocin or magnesium sulfate, and something's not working in the system, so we need people at the lower level, at the district level, to push and advocate for those things to become available. And it's very important, I think, with maternal health, where it's often undervalued.
And do you find that sort of using that approach, scorecards as an accountability tool, does it work better in some countries than others?
Works quite well. I don't think we've done that level of analysis. We use it a lot in Nigeria. In Nigeria, there are lots of things like facility health committees that work very well. Mm-hmm. But I think for us, it just helps us to really disentangle what are the changes that need to happen locally, who are the power brokers that can help those kinds of changes, and then what are the changes that need to have advocacy at a higher level that then local people or health managers or district level teams can help to advocate for. I'm not sure about different countries, if I can make a judgment on that.
Oh, okay, thank you very much. Yes, some more. Are these other experiences of using politics in health systems?
no, mine is a question. I think I wanted to ask a question.
Is it on this theme?
If
If not, would it be okay if we come back to you in a couple of minutes?
Okay, on the presentations, I wanted to ask.
Sure, we'll come back. We'll come back to you. Can I just get a couple more experiences of people who are self-consciously using politics in their health programming?
I'm Rodion Kraus from Health Partners International. We've been working in northern Nigeria for previous 7.5 years in a comprehensive program to strengthen maternal, newborn and child care that looks at all dimensions, all the pillars of health system strengthening, as well as community engagement. And so politics pervades absolutely every level, from the politics of funding of healthcare and the release of funds. Earlier on, the comment was made, have any of you experience in terms of, Lindy was talking about the preference for procurement in that type of environment. Procurement around drugs and building is preferred means of spending money, simply because you can siphon off a lot. You award contracts. So routine funding of health system is far less attractive. The politics of human resource allocations, ghost workers, the patronage system amongst health workers. So when you start talking about access to healthcare and you start finding that the people that are employment aren't delivering healthcare because they are actually providing, there's another role for them being on the payroll. So that there's so many dimensions of the involvement of politics in the system. We've heard quite a few references to, in human resources, the power of doctors. But what about the power of nurses and the power of midwives? In Nigeria, the topical issue is that most of the midwives, the trained midwives, work in the urban centres of the main capitals. In Katsina State, 90% of the midwives live in the capital city, 6 million people outside. So the real issue is, how do you get people into rural areas? And then the big discussion in Namibia is, well, what about a mid-level health worker that does deliveries? And of course, the midwives aren't very keen on that. So there's a whole politics around actually enabling a mid-level health worker profession. So the big topical discussion now, which is really about the politics of power, task shifting, the hot issue isn't so much task shifting from doctors to nurses or others, but it's actually task shifting from professionals to mid-level health workers, something in between the community health work on the one to the other. The last point I wanted to just make about the politics and the attention at community level, we're talking about community community groups. We've been running, we ran a community engagement program in all of our states, covering a cohort of about 5 to 7 million people with about 33,000 volunteers. So it's probably one of the largest, if not the largest, cohort of community engagement done entirely on a volunteerism basis. What was interesting is, yes, it's true, men are there, but men need to be there, especially if you're talking in a Muslim environment around the permission to access to health services, etc., etc. So at those community dialogues, they have to negotiate a changing paradigm and the ability of the family to access services without men being there. Men understanding the issues and why it's necessary for their wives to refer to health services or their children and so forth. But there's another dimension too. What we found, and this comes to the quality assurance things, is that we did a cluster study and found that 80% of the childhood deaths were accounted for by 20% of mothers. When we then started, and this is a universal, we did in all of our states, but there are similar parallels in other countries. When we looked at who was coming to our community engagement, the mothers that were accounting for the deaths weren't coming to community engagement because they were marginalized. So you can have a lot of community engagement, but actually find you're not reaching those that are accounting for all the deaths because they're so marginalized. So we had to then stratify our community engagement and make sure that we set groups that were safe for them to come in because of the type of people. Thanks.
So maybe this is an example of adapting your programming to data as it becomes available, and modifying your strategy to address some of these
And
issues.
innovative approaches,
Yeah.
yes.
Great, thank you very much.
Hi there, I am Stacey Cram from Namati. So we take a legal empowerment approach to health policy. I'm going to talk about our work in Mozambique. So legal empowerment at a core is, tied to the social accountability world, but it's about knowing the law, using the law, and making laws. And so the approach that we have taken is in Mozambique to train local community paralegals. And they're armed with knowledge around health law, but also, like Vicky was saying, around those skills. I mean, you pulled them out: negotiation skills, advocacy skills, as well as basic legal skills. These are trained individuals embedded in the community who will run community consultations, much like a community scorecard, coming up with the social accountability. And they will outline, so their community is aware of what should be in their health centre, what drugs should be there, what services should be provided. And therefore they will know if they're not being met with those services. There are people in their community they can go to, a community paralegal, who can take up their case on their behalf. So it's not about everyone in the community being empowered or having these skills, which are just people think that they're able to do. Not everyone can go and negotiate with these different levels. We then track all of our case data. So our individual cases are tracked. We use Salesforce, which is slightly more difficult, and so it involves more training. Some of those case forms have to be sent up and, analyzed by someone else. But we're trying to work on that. But we take this case data and aggregate that to tell a better story around how, at the district level, different health facilities are working, what are the key problems that are being reported against all of these different places. And then we take that up to the Ministry of Health. So we've been working with the Mozambique Ministry of Health, who passed this policy in 2010, but we're seeing no advancements in certain areas. And so now they're able to know what exactly is going wrong in the supply chain, like where within the provisions is that breakdown? Is it that the money isn't reaching the facility? Is it that the drugs isn't there? Is it that it's a discrimination? Is it that people aren't using the services if they're doing, more just analysis on the health facilities themselves? And
so the ministry has welcomed Namati's involvement here?
Yeah, so we're now working with the ministry on a sector-wide quality approach to and humanization approach to the healthcare.
And how was that connection made? Because that sounds quite unusual to me. I don't normally think of paralegals being involved with health ministries.
It's something that we've been working on. We've been trying innovations in different fields with a legal empowerment approach. And in Mozambique, it was the health sector that pulled this up. Legal empowerment is based on a healthcare model. So it's that idea, in the way that you have community healthcare workers backed up by a doctor at a district level, you would have community paralegals who are backed up with a lawyer should it get to the point of litigation. And so I think there's been a lot of learnings between those two sectors, and so when it came to applying it, they looked at the health sector as a natural way that you could begin to apply that model.
Okay, that's very, very interesting. Thank you very much. Can we go back to this gentleman over here who had a question?
My name is Said. I don't represent any organization in this forum, but I have some experience working with in the public health, as well as in humanitarian, as well as development sectors. I have a couple of things to ask. First of all, I do understand that public health without community health workers most probably doesn't exist or is difficult to implement. However, in my experience, we have had some difficulties of retaining those community health workers once they are trained, and especially if they are volunteers. Another NGO comes in, starts a recruitment drive, and attracts these people, and then you have to start from square one. And other times, if they are paid, it's also very difficult. One is the project fund runs out. Community cannot pay them, and then they go. So the thing is, yes, they are very important conduit for the implementation of the public health. However, the maintaining and sustaining them is another one. So I would be interested to hear about how to also, what happens beyond the project and transition from the project to the district level to the longer term sustainability. I think that will be an interesting area to say. Another question is particularly for Lillian. In Kenya, we have currently there are 47 counties. Before there was a centralized government, a very powerful centralized government where all the health budget goes to the Ministry of Health, and now it has divided into 47 counties with 47 authorities with 47 interest groups and all what associated with it. So how that particularly affected the delivery of specifically for the public health at the MCH, at the community level. And also in that context, I know in Kenya that there has been counties that may not have at all even one single trained a nurse, if I'm not mistaken. So how that this devaluation where the people politically, there is a political decentralization, is that political decentralization so something good for the healthcare?
Okay, thank you very much.
That's another question I have. If I may.
Can we keep it at 2, and we'll take a couple more, and then we'll get the panelists to respond. Somebody else from the audience.
Thanks. Dan Jones from WaterAid. I found it really, really helpful, Vicky, to look at your SWOT analysis and to think about advocacy and political engagement being kind of key capacity gaps. WaterAid has a new strategy which focuses much more than previously on influencing and advocacy. And so our country teams are really challenging themselves to shift from the kind of traditional building taps and toilets to being political, to focusing on district-wide approaches, sector strengthening, and also integration across sectors, so with health primarily as a really key issue. But those are really big shifts for those teams. So we've talked a little bit about it, but I wondered if you had ideas or examples of good versus bad approaches to building advocacy capacity and not drowning people in guidelines and toolkits.
Yeah.
Okay, thanks very much. And there's another question from online here. This is from Michelle at the Gates Foundation. And she asks, how do you ensure something as complex as adaptive advantage can be systematized? Have you any strong examples of building local management capacity to eventually deliver adaptive programming without donor resources? So 3 questions there, or 4. There's one on community health workers, one on decentralization, one on good and bad practice, and then one about whether we have any examples of really delivering adaptive programming without donor resources. And I'll start with you again. Yes, please.
Okay. So I will start with the question from over here on this issue. I think it was a double issue, really, of going from project-led to embedded, both for community health workers and for quality improvement. I think with the community health issue, there's with countries who are struggling with this issue of a lot of vertical programs and external NGO players in the community health world, then I think this is a political issue again, and it's how to harmonise and to coordinate those programs so that they then become part of a national system. Because I don't think that we really think that a lot of NGO-led community health worker programs is the way forward. And particularly if you've got national programs where those, at the lowest level, those people are volunteers rather than paid workers. Because you will always have this problem that they will go and work for the NGO program and leave the voluntary sector. So that's a political and policy issue. And when it comes to how would you embed the quality improvement, I think that's exactly what we're trying to get to the bottom of. And what we that's, I think, the crux of this whole debate, isn't it? Is how do you engage with external donors to begin with, and when you go from external donors from the project to embedding it into an idea of quality that is institutionalized. And Vicky pointed out that she has done a lot of external facilitation, and that's a very powerful thing to be able to do. What's the step after the external facilitation? Do we need to have embedded quality improvement that requires ongoing external facilitation, or is it that we can use these champions that she mentioned to embed it more deeply? And I think that's probably the next step from external to embedded. Yeah, I think I'll leave it at that. It's quite a lot of questions.
Thank you. Can we move to Lillian now, if you're still on the phone?
Yes, I am. Can you hear me?
Yes.
Okay, I didn't quite get the question directed to me, the one on the counties. Would you please repeat that?
Would you mind repeating the question about county government in Kenya in as few words as possible?
Yes, the question is basically in Kenya, currently you have 47 counties. Before you had a centralized government with one ministry. The budget used to go to the ministry, and now it is divided into 47 counties. When, particularly on the issue of public health, has this been an improvement in terms of quality as well as in delivery, or how do you assess in that context whether it is a good thing for the community, or is it something that's not as good as the political decentralization?
Okay, Lillian, did you get that clearly?
Yes, I did. So the decentralization has been that the central government would have the health budget and then would decide how it's allocated between the 8 provinces there were. But now it has to be divided among the 47 counties, and there's a formula they use for doing that based on population and other factors, the number of facilities, the size of facilities. And what we've seen is that it's two-way. There have been benefits, but there have also been some challenges. The benefits are the counties have been able to prioritize their needs. So now it's not, you can say that the problems I have in this place are, for example, my maternal mortality rate is very high, so I'm going to invest more in addressing maternal mortality. Or HIV is very high in my county, so I will prioritize that, which wasn't quite there before. So it's a very good opportunity. But because of the whole transition process, it's been very difficult. It was rushed and wasn't handled very well, according to most people in the country. It means that the systems were not ready to handle the resources, and the counties were surprised by the health, the wages. The wage bill was very high, and it took away most of the resources they had. And the same funding that is given to counties has to be allocated between health and all the other ministries, including agriculture, education, or whatever else they feel is their priority. So that has been a bit of a gap, and in our opinion is a major issue that needs to be addressed. Just building the capacity of counties to prioritize budgets and to know what to budget for, how much to budget for, especially for health and health things. So there are some who have managed to put money, for example, in community health, and that has been a benefit for us, and it's one of the entry points we're using. For example, one of the counties we are working with for Reach Out actually put in a budget for community health, and in terms of trying to rethink it and their approach. It's just that it's also taking long, and they have had, all counties have had cash flow issues. So it's something we are watching, and we're trying to engage with and see how do we get what is best, the best outcomes that we can for the different projects that we have, and especially around community health, and not forgetting that. I'll also try the other question about example, the question from Michelle about any strong examples of building local management capacity. For example, as an organization, we've done a lot of work on HIV testing and counseling and starting the first VCTs in the country and scaling them up. And it moved from a point of being NGO-led to being national country-led. And from the whole process of the VCT sites being scaled up, the government actually recruiting the task-shifting counsellors to support that process, putting in quality management systems in place, which we supported but were then taken up by government. And it's led up to the point when it's the managers within the government itself who would be able to prioritize what needs to be done, coordinate partners and the MOH staff to deliver national level campaigns to really scale up HIV testing and counseling, such that the knowledge of status in the country is very high. Unfortunately, I wouldn't say it's been done without donor support. As we know, Kenya is heavily funded for HIV work, so what the government does is, because that is already well funded by donors, then they don't invest as much. But what the national government ministry would do is that whatever money that came to the ministry was then managed by the ministry and was able to achieve national level results, which are sustained up to now. Thanks.
Thank you very much. Miriam.
I'm going to talk to the question about retention motivation. To me, retention, motivation and quality are clearly linked. And we have to look, it's very political, and we have to look no further than our junior doctors in the NHS right now. 52% of our junior doctors are not retained, do not go on to higher specialist training within 2 years after qualifying. So we are training, subsidising medical school, training them through house jobs, and they're going to Australia, to anywhere, because they're not motivated. We can't retain them. And in the NHS, we've systematically been eroding intrinsic motivators, the things that we have been finding out from Reach Out about community health workers. People like to have patient contact. They like to feel they're learning. They like to feel they're working as part of a team, that their supervisor values them. And in the NHS, we've systematically eroded that. And then we have this extrinsic motivator, which is salary. And now we say, oh, sorry, we're going to cut that and make you work longer hours. Is it any surprise? Because we've removed all those intrinsic motivators. So if we say retention, motivation and quality are not linked, we're kidding ourselves in a political environment. And I think that's as true in any setting where we're at. And to carry on with my NHS analogy, quality improvement initiatives is not enough. Quality improvement is institutionalised in the NHS. It's a legal requirement in the NHS. It's part of revalidation. We all have to do audits. We all have to do QI. We all have to be revalidated against our quality improvement on a 5-year cycle, or we can't remain as practicing doctors. But it's done in an era of funding cuts and of efficiencies. Do your quality improvement project to see how you can be more efficient. And then we'll reward you for doing such good quality by taking away half your departmental budget, for example, because you've showed that you can use this cheaper generic or whatever it is. So quality improvement is not a salve for this issue, and it's not an efficiency tool. It's about actually improving quality of the experience. And if you look at the media, you can see easily that the quality of the service people are getting in the NHS, they perceive to be going down. So it is above and beyond embedding and local ownership of quality, and it's about these innovations, and it's about supporting and working with our healthcare workers within that wider political environment. So, yeah, that's what, it's a bit beyond, I think, what you asked, but it's very overlapping.
Yeah, it's interesting. There's a famous book by Judith Tendler called Good Governance in the Tropics, which is about community health workers in Brazil. It must be about 20 years old now, this book, but that's very much about how intrinsic motivations caused a breakthrough in the local health system there.
Maybe just for the online audience that's not from the UK, we've currently had a junior doctors strike for the first time in 40 years that doctors have been on strike, and we have another strike day planned on the 10th of February, which will be a full walkout, including emergency cover not being covered for the first time, I think, ever since the NHS was founded.
Yes. Vicky.
Well, I don't know what to say now after that. I was hoping someone would give me the answer to your question about building examples of how to build capacity in advocacy, communications and negotiation, because this is, the more I look at different health programmes and projects, the more you realise there's a clear skills gap in this area. And so I would really like to put that question back to the audience if they've got good examples. The only kind of thing I can think of that we've done in quality improvement projects is that very much promoting as a team approach, multidisciplinary team approach, and sort of instigating some recognition and award schemes where different teams will present their findings in national forum. So they are advocating and promoting certain ways of doing things using their own real data. So that has been one way we have tried to develop that kind of advocacy influencing skills. But I think that's something which we were hoping that maybe others here could also tell us about, of examples of how they've managed to do it, because we'd love to learn.
What?
Could I have a reflection on Miriam's point?
Yes,
very briefly.
Quickly, because we're running out of time.
I just wanted to put out the question, to what extent we would think of quality improvement the way we do it in the NHS as adaptive programming, because I think when we look at that kind of institutionalised quality improvement, which is what we're saying we're after in the programmes that we work on internationally, it's actually something that looks a little bit different. So it may be institutionalised, but it might not be what we want to deliver, and is embedded in that sense going to work if we try and embed it internationally. And who is making those priorities? If QI in the NHS is about efficiencies, then that doesn't seem to be the junior doctors who are driving what the priority setting is. So that was just a quick reflection on that issue.
Okay, well, on that note, I think we're going to have to bring this to a close. I think we've had a lot of interesting presentations and a lot of interesting feedback from the audience, which has confirmed the idea that politics is important to quality healthcare and important to quality improvement. And we've had some examples of how people are coming to terms with that and actually embedding that in their programs. One of the things we're doing in POGO at ODI is to try to think a bit more systematically about how political context can affect elite commitment to certain sorts of policy changes and their ability to implement those. And I think we may find that the type of political context you are in should affect how one goes about trying to embed quality, that the way you try and embed quality may well be different in different country contexts. And also there may be some country contexts where it's actually unrealistic to expect a local capacity to embed quality improvements in the near term, and that actually what's needed in those kinds of contexts is an over-the-horizon donor commitment to trying to institutionalize these practices. So it's down to me to thank you here for attending. Thank you to those people who followed us online. To thank the speakers, to thank Lillian in Kenya, And to remind you all that the event video and recording will be available online within the next 48 hours, as well as PDFs of all the presentations. So thank you again.